Okay, this is elbow dislocation or instability associated with bony elements. The bony element, of course, is for prognosis. What are the bony elements which are associated with? We have radial head, coronoid fractures, transolecranial, terrible triad, and posterior medial fracture dislocation. The most important that we see is the radial head fracture, which is about 30% of the bulbous instability. This is a second destabilizing factor, and mostly when it's torn, I have to look for the medial collateral ligament and other ligaments affected. With the patient with intact medial collateral ligament excision of the radial head, it doesn't make instability. Why? Because we have medial collateral ligament. So, patient with radial head fracture, I have to just support medial collateral ligament, otherwise I will make the patient in instability. Radial head must be reconstructed or replaced. We have multiple types of reconstruction. We have silicone head, we have titanium head. Anyway, the radial head must be retained. Okay? The coronoid fracture. We have what's called Regal Moni classification for coronoid. You know the coronoid. You know the area of the coronoid. This is the coronoid. Okay? We have three types of the coronoid. Type 1, type 2, type 3. And type 1, this is small tip will be fractured, this then 50%. Okay? I have to ask one of our colleagues. This is an avulsion fracture. What ligament is attached here? Wrong. Coronoid. This is an avulsion fracture. Okay? What's the ligament attached to? تمام. عرفت. تقول هنا الى anterior capsule. Okay. This is wrong to be said avulsion fracture. Nothing is attached to the tip of the cranium. Tip of the cranium is a fracture. This is an indicative of a trial of elbow instability or perched dislocation, and then nothing to be done. How to treat? Nothing to be treated as long as the elbow is stable and nothing associated. Type 2, 50% only, up to 50% of the olecranon is dislocated. And also, no dislocation, no treatment. Type 3, more than 50% is dislocated, must be treated. Why? Because here there is attachment to the medial collateral ligament. قلنا ان هو يجي attachment على anteromedial surface بتاع الكرونويد او البيس بتاع الكرونويد. هنا must be treated. We have multiple treatment types. Of course, we have another classification or Driscoll classification. Tip or anteromedial or basic. Multiple types of treatment. Of course, speaking about type 3, we have either to make medial. We have made osteotomy at the flexopronator origin and elevate all the muscles and reach anteriorly or anterior through the olecranon. Or we have percutaneous vessel repair. This is a recent type, just to make string come around the olecranon, come around the tip of the coronoid and make drill holes on the olecranon and type it outside. This is the type to be done, maybe done percutaneously. من غير ما افتح الفليكسوبرينيتور اوريجن واقلب كل المصل دي او اطلع انتيريور واخش ما بين الدايليما بتاعت البيس المجرد. ممكن اخش بس مجرد بخيط حوالين الكورونويد واشده لبره وانزله انيمها على الكورونويد. الفكره كلها تو جين الكونتينيوتي بتاعتها. تمام؟ تربو تراياد احنا عارفين كلنا تربو تراياد including elbow dislocation, radial hip fracture and coronoid fracture. Okay? Must be managed, must be done by correction of the elements, of the bony elements must be done. Otherwise, one alone will result in failure. For example, radial head fixation or replacement alone 50% failure without treatment of the coronoid fracture, without treatment of the ligamentous around. Okay? We have here, in this condition, we have to make ligamentous reconstruction, not repair. It's completely avulsive. Okay? Other one, including posterior dislocation of the radial head, posterior medial fracture dislocation. Okay, it must be fixed and maintained because the coronoid also will be lost in this condition. This is the case of the transolecranial elbow dislocation, in which the olecranon is completely torn or completely fractured. This must be regained. Here he regained it with plate. By the way, if less than 50% of the olecranon is only lost, no elbow instability will occur. More than 50%, this is an indication of elbow instability. Okay? Hinged external fixator is the method of treatment of elbow instability. Especially, we have dynamic or static twisting. The indication of hinge external fixator, it's temporal. It may be used as temporal stabilization, or the patient can resist that elbow instability. Again, neglected elbow instability after a lot of time. We have to give him some range of motion with the use of hinge fixator, protection of comminuted radial head. Okay, maintenance of elbow stability at the setting of the comminuted coronary fracture, or providing stability in chronic artery use. This is the method of hinged external fixator, multiple hinges, making the humerus and the ulna. Just give the patient range of motion as long with, especially in chronic artery use structure. The last one, valgus instability. This is the last one of the type of instability. So we make posterolateral. We spoke about the valgus instability. Valgus instability. This was called throwing elbow. We have throwing shoulder. This is your example. We have thrower shoulder. We have thrower elbow. The thrower elbow with the valgus instability occurs mainly in athletes. Discovered first in 1946. يعني baseball player واللي هم الفوتبول American football players. اللي بيحصل هنا what occurs the medial collateral injury. What part of the medial collateral? Anterior part of the anterior bundle of the medial collateral. The diagnosis here is based on the history. The patient, of course, is athlete and speak about clicking and poking during the thrower. We have posted valgus stress test. We will test now. MRI arthrography with gadolinium is done. And dynamic ultrasonography, this is a key. This is a key. However, we have a contraindication in management of valgus instability, which is the athletes who quit treatment. خلاص العيان اللي هو كان athletic and quit his game, nothing to be done. Also, in the patient associated with humeral ulnar or radioculateral joint arthritis. The patient with arthritis is no value to look for instability. We have to look for regaining the joint. Management can be done by reconstruction of the reconstruction, not repair on the medial collateral leg. We have two techniques: joint technique, okay, and docking technique. Both of them using other type of graft, either palmaris or semi-tendinosus graft. The most important is to put it in the isostatic point of the humerus. In the medial collateral ligament, if I put just only the ligament in joint technique or docking technique in any point of the humerus in the distal humeral area without testing it may result in either tight elbow with stiff elbow or lax elbow again. So it must be done in what's called isostatic point. According to the ulnar nerve sometimes may be anterior transposed. In this case, we are taking home message اللي هنقولها. Stability of the elbow is gained by osseous and soft tissue. We have to look for soft tissue, static and dynamic stabilizers. Ulnar lateral ligament and anterior bundle of the medial collateral ligament are passwords for elbow instability. Holy cycle will define the degree of displacement. عرفنا ان الهولي cycle تبدا من lateral توصل للميديا تمشي بستيجز من lateral ulnar collateral ligament كبسول anterior posterior medial collateral ligament كله بعد الانتيريور بعدين الانتيريور بعد كده الcommon flexor pronator origin. And homework for elbow dislocation doesn't end with reduction or relocation. Regaining the test of the stability before going home, the patient must be tested. And at last, pivot shift should be done in supination and valgus test should be done in pronation. And X-ray is important to assess simplicity of dislocation. Thank you. أنا عارف إحنا طولنا